Hello friends, in this video we are going to talk about color Doppler. We need to have a very basic knowledge of Doppler, how Doppler works. For example, this is a USG probe and this is a vessel. First of all, you need to know one thing. When we do ultrasound, we do the ultrasound of tissues. But when we do color Doppler, we do color Doppler of a particular vessel. Okay, so when we see the color Doppler, what we see is vessels. What we see actually a particular vessel, and we see flow in that particular vessel. For example, this is a probe. For example, this is a probe of ultrasound, and this is a vessel. Now, in this vessel, if the blood flow is towards the probe, the probe will see it as a red flow, means towards the probe. If the flow in this vessel is away from the probe will see it as a blue. Now you know the both color, either the flow towards the probe, that means the probe will see it as red, and if the flow is away from the probe, it will see it as a blue. Now that is thing of color. Now we need to have here the waves, the graph, how the graph becomes. See, for example, when there is a systole, the flow is towards this probe. Imagine the flow is towards this probe, so it has some velocity. The color Doppler also measures the velocity of the flow also. So if the velocity is like this much, then the waveform will be formed like this. If the flow in the blood vessel, it's towards the probe but not that much velocity, some smaller velocity is there, then the waveform appear will be like this, smaller than this. Now consider another scenario. If the blood flow in the vessel is from outer towards the probe, away from the probe, then every waveform will appear on this side of the line. If the velocity will be more, it will appear more. If the velocity will be less, it will appear less. Now you understand how the waveform is there. Above the line, if we see above the line, the waveforms are because of the flow towards the probe, and the waveform below the line, we see the waveform will be formed below the line depending on the velocity of the flow. The size of that particular curve will be changed. The more curved, more velocity. Okay, you need to do this one thing. Second, again I told you, when we do a color Doppler, we do particular vessel study. In obstetric ultrasound, in obstetric color Doppler, we we see majorly three vessels. One is umbilical artery. Second is middle cerebral artery. The third one is uterine artery. You see what I am talking about? We see only three vessels. Majorly, most of the time, 99% of the time, we see only three vessels. The first vessel is umbilical artery. The second vessel is middle cerebral artery. And the third vessel is uterine artery. Why we choose these three arteries, we will see further in this video. First of all, you need to remember what is S and what is D. Let's come to here. When there is a systole in the fetal heart, when there is a systole, so we term is as a S. When there is a blood flow during the systole of the heart from which that vessel is coming, we term as a S wave. What is S wave? At S wave means blood flow during the systole. It can be both directions. I am talking about, see, when we make the waveform, like this is a S waveform, that means that the flow is during the systole of the heart, which supplying this particular vessel. And when we term D, means the blood flow during the diastole of the heart, particular heart. Okay, it can be both. It can be reversal, it can be towards the probe, it can be away from the probe, but it is the during diastole of the heart. For example, if we take as a uterine artery, sorry, umbilical artery, my fault, umbilical artery. Now everyone knows that the umbilical artery is, it comes from the fetus. So for example, this is umbilical artery. The blood in the umbilical artery comes from where? It comes from the fetal heart. So the flow in this artery is because of the pump function of fetal heart and not from mother heart. In umbilical artery, the blood flow is because of fetal heart, okay, and not from mother heart. You need to remember one thing. Now umbilical artery supplies what? It supplies the placenta, the placental bed. Okay, so now if we see waveform of umbilical artery normally, what we see this kind of waves. There is a systolic wave, that means that in umbilical artery the blood flow flows during systole, and the S is because of the systole of the fetal heart. Again we see the diastolic wave. The diastolic wave, that means that the flow is during the diastole of the fetal heart. But on which the diastolic flow depends? Diastolic flow depends on the vascular resistance of the placental bed. You know what I'm meaning? Systolic flow depends on what? Systolic flow depends on the fetal heart pump function. But the diastolic flow in the umbilical artery depends on the resistance of the placental vascular bed. If the placental vascular bed's resistance is higher, then the blood can't flow very easily in diastole. So if the vascular resistance is higher, if the vascular resistance increases, then the diastolic flow decreases. If the vascular resistance decreases, then the diastolic flow will be increased. So I am telling you very important thing. When the placenta is formed in the body in early pregnancy, the blood vessel systems is not well developed. But with the increase of gestational age, the vessels in the placenta become more and more wider, and more blood flow can flow into this placental bed. So that means that when the gestational age is increasing, the vascular resistance of the placenta will decrease. See here, when the gestational age increase, so the diastolic flow increases. Why? Because there is a decrease in resistance of the placental vascular bed because of the bigger and bigger arteries and veins. So when the gestational age increases, That means that the diastolic flow will also increase with the gestational age, and that's why SD ratio decreases. You need to remember this thing very clearly in mind. In your mind, one thing should be very clear and stout, is that means that with the gestational age increases, the SD ratio decreases in the umbilical artery in normal situations. I'm talking about normal situations. So what we do here, we do measure the systolic flow wave and diastolic flow wave in the umbilical artery. Okay, now let's go ahead. The end diastolic flow, when we measure the flow, actually during the diastolic period, we measure the flow at the end of the diastole, so it is called end diastolic flow. EDF means what? The end diastolic flow. That means we measure the flow at the end of the diastole of the fetal heart. Now, what scenarios can be there? Three scenarios can be there. Reduced flow. One is reduced flow. Reduced end diastolic flow. That means when the diastolic flow is decreased, what that means? That means the vascular resistance in the placenta has increased, and that's why the diastolic flow decreases, and that's why the SD ratio increases. SD ratio increases when there is a vascular resistance increase in the placental bed, and that waveform is like this. See, the systolic wave is well and good, but the diastolic wave is smaller. You see here, the diastolic wave is smaller, and that's why the SD ratio has been increased. And when this happens, you know one thing, that the vascular resistance has been there. So placenta is not well developing as it should develop with the gestational age. So there is a problem, but it's not a very severe problem. What we need to do is we need to do monitoring, very close monitoring of the fetal status with the help of NSTs and tochocardiography and like that. We need to monitor this baby. There is a risk. Now, in the second scenario, there is an absent end diastolic flow. Means at the end of the diastole, the flow is absent. What that means? That means the vascular resistance is so much higher that at the end, in the diastolic period of the heart, the flow can't happen. The placenta doesn't allow the flow during diastole. Why? Because of very high resistance. And in this scenario, the SD ratio is very high. So this is a very high risk baby, and we need to terminate the pregnancy. But in this case, what we prefer is, we need to prefer that the baby should attain lung maturity, that is at 34 weeks. So we generally wait for 34 weeks. We monitor closely, but we wait till 34 weeks so that the lungs of the baby are matured, and then we definitely get delivered by cesarean section or whatever the means. The third scenario is reversed end diastolic flow. You see the waveform here. The diastolic flow is reversed. What happened in the diastolic flow? That means the placenta has become so severely resistant that in the diastolic flow, it actually rebounds back. In the diastolic period of the fetal heart, placenta actually throws your blood towards the fetus, that they don't want more blood. So placenta is very highly resistant in these cases, and this case should be terminated as soon as possible. Otherwise, in 1 or 2 days, the fetal will be die. So this is a very grave conditions. So three different scenarios I have told you in this umbilical artery color flow. You need to remember this waveforms. Okay. So this is because of this thing. Now, two another indexes are the resistance index. We measure it as a S minus D divided by S, and the pulsatility index we measure as a S minus D divided by the mean. They have their own importance, but we don't need to know about this at this place because this is a very basic video for color Dopplers. Now, second artery we talk about is a middle cerebral artery. In middle cerebral artery, what happens actually? In middle cerebral artery, the vascular bed is already resistance. Normally it is resistance, and it is not going to be decreased with the age, gestational age, as we have seen in umbilical artery. What is our focus when we do MCA Doppler? Our focus is to find out the high flow when there is a fetal anemia because of any condition. The most important condition is of Rh negative isoimmunization, in which the fetal anemia develops. And when there is a fetal anemia, you know this, when there is anemia, the viscosity of the blood decreases and the cardiac output highly increases. When there is a fetal anemia, what happens? The systolic flow is very high. So the systolic waveform is very high. And what we measure here is a peak systolic velocity. In fetal anemia, systolic velocity increases. For example, this is a normal waveform and this is C. Systolic waveform is very high. Diastolic is same, but systolic is very high. That's why SD ratio is increased. See, you can see increase in SD ratio, but SD ratio is not important here. What important here is peak systolic velocity. That is important, PSV. If the PSV is increased, that means there is a fetal anemia. There is a very high flow happening in the MCA, and that means that is anemia. The second importance of MCA flow is because of IUGR. When there is an intrauterine growth retardation, the brain is spared. All other organs have the problem, but brain have less problem at last because brain is spared. And when the brain is spared, that means the body of the fetus wants that the brain should get more blood flow, because already there is a IUGR, there is a fetal hypoxia, and they are not getting enough oxygen. So brain wants is what? Brain wants that more and more blood flow brain wants. So what it will do, it will decrease vascular resistance in the brain vascular bed. So vascular resistance will be very less. That's why the diastolic flow will definitely increase high. So actually here SD ratio decreases because of the diastolic flow is very high. Like that. It is the systolic flow. Diastolic flow is not very less than this. Systolic flow is this, diastolic flow is there, but not very less, as actually it should be. So this is SD. So in this case, what we see is there is a brain sparing effect. The third vessel we are going to talk about is uterine artery Doppler. Now, the two vessels we discussing before were the vessels of the fetus, where the fetus, where the vessel, the blood comes from the fetal heart. But in uterine artery, the blood comes from where? Maternal heart. Now we are talking about maternal heart. So it has a very different waveforms. Now, the uterine artery per se is a very large artery with so much of muscles in that middle layer of the artery. So it has impedance. Impedance means elasticity. The uterine artery bed, vascular bed, is an elastic one bed. So what's seen here, when we talk about color Doppler of uterine artery, the systolic wave is like this, and there is a diastolic wave, but there is a diastolic notch here. The diastolic notch is because of the elasticity or impedance of uterine artery. Impedance, diastolic notch is due to normal impedance of uterine artery. It is seen in early pregnancy because again I am telling you, when the pregnancy is developing gradually, there is a resistance in uterine artery in early days of pregnancy, but as the pregnancy is advancing, the uterine artery impedance going to be decreased, so the notch will be going to off. So as the gestational age increases, the notch will disappear. The notch will disappear by 22 weeks. But if the notch is not yet disappeared, even after 22 weeks of the pregnancy, what that means? That means that the uterine vascular bed is still very resistant. It is not well developed, and it happens in preeclampsia. So it is a sign of developing preeclampsia. So this is how the thing works. You need to remember one thing clearly, that what we do in color Doppler is we see a particular vessel, and when we see a particular vessel, we should know this thing, that the vessel comes from which heart, maternal heart or fetal heart. And again, when the SD ratio, when we talk about S and D, the systolic and diastolic flow, the systolic means the flow during systole, and D means the flow during diastole. It can be either towards the probe or away from the probes. It doesn't matter, but it only matters that the flow is during the systole and the flow is during diastole. Now every flow has its velocity. It can be higher velocity or it can be lower velocity. It comes on the waveform. Thank you.